Okay, we're now going to do chapter 35b from the book The Medical Reformation by Peter Rogers, MD. Oh, by the way, if anybody wants to help me out, if you've been watching these videos, I would appreciate it if people would write a review over at Amazon.com, mentioning what you thought was good or bad about the book. It's okay if you think the book stinks. Go ahead and say that. Just at least somebody paid attention and was aware of it. All right, so anyways, if you're following in the book, we're on page 476. In 35A video just done, we talked up until this point here about electron transport chain of the inner mitochondrial membrane. How basically the hydrogen atom is split and the electrons are passed down like a fireman bucket brigade from the weakest grabber of electrons to the strongest grabber of electrons, which is oxygen, the ultimate acceptor of electrons, and the oxygen is converted to water. Whereas the energy of passing the electrons, downhill, so to speak, like a snowball gathering power as it rolls downhill, hydrogen protons are pumped into the intramembranous space between the inner and an outer membrane of the mitochondria. And then that's like a built-up gradient, an electrochemical gradient that is harvested by allowing a hydrogen to come back into the mitochondrial matrix, and the energy of that returning along its electrochemical gradient is used to add a phosphate to an ADP, adenosine diphosphate, and make an ATP, adenosine triphosphate. And this is how most ATP, which means most energy in the human body, is made. The mitochondria has the highest electrical gradient of any system in the human body that I'm aware of. It's negative 160 millivolts. That's incredible. So this is like the electricity power plant, of your house, okay? And then the plasma membrane is like a battery. All right, so anyways, we're going to move on to some new stuff in this chapter here about what is cancer. All right, this next chapter is an important one. This next slide here is an important one. And, you might want to hit the print screen button on your computer. You could save these slides, okay? I want people to learn from this. You can make your own little PowerPoint presentation based on these slides. Just hit the print screen button and use a photo editor to, or your PowerPoint. You can crop it in the way, whatever way you want. Okay, so here's the point about cancer. A normal cell is mostly a worker. Let's say you are a liver cell. You have a job. You have to maintain the blood glucose level by running gluconeogenesis, breaking down glycogen, storing glycogen. You have to detoxify things. You have to produce bile. Okay, that's what a liver cell does. It needs tons and tons of ATP. So the focus is on making ATP. So it's drawn in big letters here. You need a little bit of protein synthesis, make a little bit of nucleic acids, but not much. All right. Now here's a cancer cell. A cancer cell is different. A cancer cell is like an anaerobic bacteria. Its job is just to replicate itself as fast as it can. So all it cares about is making more cancer cells. It's not going to do any work. It's kind of like Johnny Paycheck. It says, take this job and shove it. Okay. It primarily runs on anaerobic glycolysis, and that's why it needs tons of glucose. Typically let's just say about 100 times more than a regular cell, and that's why it's positive on PET scans, fluorodeoxyglucose PET scans, and that's what they use to check cancer patients whether or not they have persistent disease or metastatic disease. Okay, so its focus is on synthesis, not on energy production. So it needs to make tons of proteins, tons of nucleic acids, because remember, its goal is to replicate itself. So in order to replicate itself, it has to first of all, make a copy of everything that it has. The human DNA genome has 3.3 billion base pairs, so it has to make 3.3 billion base pairs more DNA. That's a lot. Okay, and it also has to replicate all the other contents of the cell, all the proteins, the lipids, etc. So its focus is on synthesis, and it can do all kinds of weird things like run Krebs cycle backwards. Okay, and so basically, how do you stop cancer? What I would consider an intelligent thing to do is don't give it the stuff it needs to make all these copies of itself. Slow down the replication process. Slow down mTOR. That's what I would try to do if I had cancer. Okay. Yeah, the ATP is like a $20 bill in a cell. It's the energy for getting stuff done. Okay, we talked about how hypoxia damages mitochondria, and the cell can transform itself into becoming like an anaerobic bacteria. There's 3.3 billion base pairs of DNA. So yeah, what would I do? I would deprive the cancer of leucine and methionine. The leucine especially is used to activate mTOR, the nutrient sensing pathway for growth replication. It also needs iron, lipids, and methionine. Okay, so I would deprive it of that. Here's a bacterial life cycle. Basically, it's dormant, and then resources become available. It rapidly grows, hits a plateau phase, and starts dying. Okay, it's it's just stupid. Okay, it's a bacteria. All right. Let's see. So again, a strategy is rapid growth and try to spread to other locations, and that's what cancer does. Okay. All right, so now here's a key metabolic change in a cancer cell, and that is an upregulation or an increase in the enzyme hexokinase 2. Hexokinase 2 enzyme is abbreviated HK2, and it'll stabilize the outer mitochondrial membrane, and it'll block a Bax apoptosis pathway. And this will prevent the cancer cell from dying and enable it to become immortal. Okay? So this is one of the key common things you're going to see in cancer. And that's also why I think the somatic mutation theory is BS, because it's not just one mutation, one change one day. It's a whole new way of life. Okay? Hexokinase 2 is going to phosphorylate glucose, and it's also this enables it to get energy, the little bit of energy that is still produced by the mitochondria. They don't completely stop working. They're just diminished in function, typically, the mitochondria in a cancer cell. And again, I talked about how this being, I think, reversion to primitive pathways to survive in low oxygen conditions. Now, here is an example of a grape. A grape is about 5 grams. All right, I show you that just to get a sense of size. Now, here's a nice diagram, and I first learned about this from Dr. John McDougall. Okay, he was given a lecture on cancer, and he showed that you have a cell of origin. Typically takes, a certain doubling time. Let's say it's 100 days to become 2 cells, another 100 days to become 4 cells, another 100 days to double and become 8 cells. So anyways, you can't see cancer in the human body. We don't have any tests to detect it when it's in these small of an amount. Okay, usually it's going to have to be close to a centimeter before we can say it's cancer. For example, how soon can you see a cancer on a chest CAT scan? We always see little micronodules, almost always. Most patients have them, of anywhere from 3 to 5 millimeters. And when they're small, we don't know what they are. And by far, most likely, they're just old scarring from who knows what, when you had an infection when you were a kid or something. I tell you that because, Dr. McDougall's pointed out, usually by the time we can see a cancer on a mammogram or on a CAT scan of the chest, abdomen, and pelvis, it's usually already spread. It's usually already metastatic. Okay? Now, don't get me wrong. There's some cancers that never spread. There's lots of them that never spread. But you don't even really want to know about those. In a previous slide, I talked about rabbits, turtles, and vultures, and how most cancers are actually rabbits, and you don't want to know about them. Vultures often kill the patient so fast there's nothing you could do. And what most people think is cancer is a rabbit. So that's an important point. Now, don't get me wrong. If you look at a mammogram and you're looking at an older woman, let's say she's 80 years old, the breast is mostly fatty, and it's going to be relatively easy to see. But you get a younger woman, let's say a 40-year-old, she's got lots of active breast ductal tissue, and it can hide things, and it makes it very, very difficult to interpret a mammogram. Okay, that's why mammograms don't work so well in younger women, premenopausal women. According to Dr. McDougall, he says that metastatic lesions typically have a doubling time similar to the rate of the primary tumor. And there's other things that factor into it. If the patient's immunosuppressed, the cancer might grow more rapidly. That's another reason why I'm a big believer in trying to maintain optimal function of your immune system, because it's your immune system that removes cancer cells. All right? And this is an important slide. If you care about cancer, you want to hit the print screen button and save this slide. Okay. By the way, I wrote an entire book specifically dedicated. I called it Poor Man's Guide to Cancer, where I go through most of this pathophysiology. Okay. This book, Medical Reformation, covers multiple topics, including cancer, of course. Okay. And I got detailed index in this one, the Medical Reformation. Okay, I don't remember if I had an index or not in the Poor Man's Guide to Cancer. I made videos about all this stuff too. I'll make videos about each individual topic in more detail. Now I'm going through these topics in the context of book chapters, from this book. I'm going by the book. Okay, but here's an important point. A 1-gram tumor, pretty darn small, can shed over 1 million cancer cells into the body, into the blood in one day. Okay, so we talked about a tumor as small as a grape's about 5 grams. So when you have a tumor that's just 1 gram, it can shed over 1 million cancer cells into the blood in one day. I saw the papers confirming that. What do you think removes those cancer cells? It's especially your immune system. You know, a lot of them go into the blood. They can never anchor and survive. But your immune system, you need it to remove them. So, okay, well, here's the paper. Quantitation of cell shedding into efferent blood of mammary adenocarcinoma. So that just means the cancer releasing cancer cells into the blood. So you want your immune system to function well. So you want to get your sleep. That gets your immune system to work well. You want to avoid being stressed out because that elevates cortisol, worsens your immune system. You want to avoid caffeine because that elevates the same hormones as stress. Cortisol and the catecholamines, all right? Catecholamines are just adrenaline and noradrenaline. Also, you want to avoid caffeine. You want to avoid sleep deprivation and excessive psychological stress because all of those things increase cortisol. All right, chemotherapy tends to suppress the immune system, so that's another good reason why, unless the chemo is shown to really, really, really improve longevity and outcomes, I wouldn't just take it for the heck of it, because if you take it just for the heck of it, there's no proven benefits in that context, and it's going to probably damage the immune system. So does that sound wise? Your immune system removes the cancer cells and you want to wipe out your immune system? I would look into that carefully before I would agree to it. Okay, now here's some work of Thomas Seyfried, PhD, and he did some brilliant experiments showing that cancer comes from the mitochondria and the cytoplasm, and this is consistent with the metabolic theory of cancer, and not from the DNA, which is what one would expect if the somatic mutation theory of cancer were correct. So basically, here's what Thomas Seyfried did, and he wrote a book called Cancer is a Metabolic Disease. It's a good book, and he has some good lectures on the internet. You can see his lectures. I think Thomas Seyfried is very smart about his explanation of the metabolic theory of cancer. I don't think he knows nutrition too well. I don't agree with him on his nutrition recommendations. I actually think they're wrong in my opinion. Okay, so here's a normal cell, and it divides, makes a copy of itself. That's normal growth. Here's the DNA, here's the mitochondria. Okay, here's a cancer cell now. So I drew the cancer cells in red. Cancer makes a copy of itself, DNA, mitochondria. Okay, fine. All right, so now here's a cell where they took normal cytoplasm and mitochondria. There's the mitochondria right there, characteristic shape. Almost looks like a little peanut. And here's the DNA in red that came from the cancer cell. So when you have this hybrid cell, you don't get cancer. That's an important point. It wasn't the DNA causing cancer. Versus if you take the cytoplasm here in red, like our original cancer cell, and the mitochondria from the cancer cell, but you use the DNA from the normal cell, you still get cancer. So the DNA didn't determine things. It was the mitochondria and the cytoplasm, okay? And that makes sense from the metabolic theory of cancer point of view, where you've got damaged mitochondria, okay? So that's important to know. That's why I like the metabolic theory of cancer, because it makes sense. It makes sense with the research of Thomas Seyfried. It makes sense with the research of T. Colin Campbell, who wrote the China study. It makes sense with what I've seen in clinical experience and what I've read, okay? It makes sense with mTOR. It's consistent with everything, okay? It's consistent with the research of Otto Warburg versus somatic mutation theory. In my opinion, the closer you look at it, the stupider it gets. And I think the Genome Atlas project really showed that it was pretty stupid. It's a good book. There's a good book by a guy who's a big fan of Thomas Seyfried. It's called Tripping Over Cancer. The author's name is Travis Christofferson. What I like about that book, he's really good at explaining things, and he goes into detail stepwise for why he thinks the metabolic theory of cancer is good and the somatic mutation theory is bad. He's kind of in the same group as Seyfried and nutrition. He doesn't know. In my opinion, they're both kind of junior knuckleheads when it comes to nutrition. I think they're kind of clueless. But they're good on the metabolic theory of cancer, and that's the first step. You want to understand a problem in a way that enables you to improve outcomes, okay? So this does it. All right, so now let's keep moving along here. Oh, he called these cells Seyfried. He called them cybrids, and that's sort of a portmanteau combined word for cell and hybrid, cybrid. Okay, fine. Why not just call them hybrid cells? Okay, so this was the point. The cell with a normal nuclear DNA but abnormal mitochondria became cancer. So the cancer-causing part of the cell was the cytoplasm and the mitochondria, not the DNA. All right, now, This was just a picture of screening. I got a picture of screening here. Basically, I think screening is kind of a joke. And I know people love screening. If you talk to the average patient, and I've talked to a lot of them, they think screening is this wonderful thing. And some patients will tell you, screening saved my life. And even the ones who suffer the complications of screening usually don't understand that they've been chumped. Okay, if you have a cancer doctor, they love screening. It gives them tons of patients. They make tons of money on this. Hospitals love screening. They make tons of money on this thing. But I can tell you, I've seen radiology departments double over the last 20 years because they get tons more patients once you start doing this. And then, from a doctor's point of view, screening is kind of nice because the patients usually aren't really sick, so they're not going to die on you, and so it's not going to be like you screwed up and the patient died because you screwed up. They're mostly almost like fake disease. All right, there's a joke in radiology. What's the definition of a healthy person? A healthy person is somebody who hasn't had a body CT yet. A body CT means a CAT scan of the chest, abdomen, and pelvis. CAT scan means CAT is computerized axial tomography, and it's usually abbreviated nowadays to CT, computerized tomography. And the reason for that is because we typically still acquire the data in the axial plane, the transverse plane, but it's so easy to reformat it now into sagittal and coronal that you don't need to call it the CAT. The A in there meant axial transverse sections in the past. Okay, so patients love screening. Everybody's happy except the stupid patients are getting chumped and they're too dumb to realize that that's what's happening. So what is screening like? What's a metaphor to explain screening? Imagine you had two people from a screening company, from the chemotherapy selling company, and they stood on top of the roof of some buildings at a shopping mall, and they had a big net drawn across between the two of them, and they threw it on top of the people walking by. That is what screening is. You take healthy, regular people and you turn them into patients, okay? And then you start making money to them. The more people utilize the medical service, the more drugs and surgeries you could sell them. Also, what they fail to recognize is that the usefulness of a medical test is very strongly related to the pretest probability, meaning that if you have a high likelihood of having a disease and you check for it, that could be useful and valuable. But most of these patients have a very low likelihood of having a clinically relevant cancer, and you find lots of false positives. A false positive, we typically call them incidentalomas. For example, let's say you go for a screening CAT scan of the chest to look for lung cancer because you previously were a smoker. Well, the smart move is quit smoking, okay? That's going to make the biggest difference. You need a low-fat vegan diet, okay? That's going to make a giant difference. And how can I say that? If you look at Papua New Guinea, where they eat 93% of their calories from sweet potatoes, which have only 1% of their calories from fat, even though they smoke like chimneys, they have more than 6 times lower lung cancer than do Americans, okay? And it's thought it's because of the low-fat diet. Okay, let's say you talk about Japanese. They also eat a low-fat diet, and again, despite the fact they smoke like chimneys, they have much less cancer than Americans who would smoke a similar amount or even less. So the diet is like as important, or really I think it's more important than the smoking for causing lung cancer. And lung cancer can also be caused by exposure to toxic fumes. Like if you're working in a chef kitchen and you're inhaling a lot of toxic fumes, that can be toxic to your lungs. People who work in a fast food place and they're always inhaling those fumes, that can be bad for their lungs. Or if they're working with other toxic chemicals, that can be bad for the lungs. Working with asbestos, for example, that's usually a different type of lung cancer. That'll cause primary lung cancer, but it'll also cause a different type called mesothelioma along the pleural space, the margins of the lung. Okay, every screening test has potential problems. Like colonoscopy, you run the risk of a perforation, you run the risk of post-biopsy bleeding, and the most common thing, too, is you cause anxiety because the patient's always worried. Most of the time the test is going to come out negative, the biopsy is going to be negative, but they worry about it for a while. And with some things, like let's say you have a little micronodule in the lung base, you're going to get followed up on that for years, at a minimum 2 years, sometimes 5 years. And there's going to be other things on these screening CAT scans, let's say of the chest for lung cancer, but it could be other types of scans. But let's say a screening scan of the chest, there's going to be a little adrenal nodule, you get followed up for that. Potentially a low-density lesion in the liver, too small to characterize, you go get an MRI for that. Then there's a little something in the kidney, possibly, abnormal kidney cyst, complex kidney cyst. You're not sure. There's noise in there because you used a low-dose radiation on the screening scan, so you can't clean out the echoes inside of it, get an ultrasound, get an MRI, all this follow-up stuff for these incidentalomas. Oh, there's a cyst in the spleen. We got to work that up. All right, you see where I'm going. There's a little bit of adenopathy in the gastrohepatic ligament. We got to work that up. You see what I'm saying. And it goes on and on and on. I've been involved in screening studies over 30 years. I currently work primarily as a neuroradiologist. I previously was an imaging-guided surgeon and interventional radiologist, and I gradually moved towards becoming primarily a neuroradiologist. I still do general radiology. I do a little bit of interventional still. So basically, what am I saying? I've been around this stuff for 30 years, and I can tell you, I don't ever go for any of this stuff, and I never would. I just try to lower my risk. Being a low-fat, low-sodium vegan, get my sleep, manage my stress. I'm religious, too. Religious people are a lot healthier. They don't like to talk about that because there's a big push to get rid of religion, but I can just tell you, they're way healthier. It's the smart group to be in if you want to optimize your health. Okay, we talked about the radiology joke. Now, here's what you need to know about cancer. These are the three categories of cancer, according to George Cryle and Gilbert Welch. George Cryle was a guy at the Cleveland Clinic, surgery doctor over there. Gilbert Welch is an epidemiologist. He's a really smart guy. He wrote an entire book about screening called Overdiagnosed. Excuse me. Sorry about that. Okay. Gilbert Welch also has a YouTube channel. You can watch videos over there if you want to learn a little bit more about screening. And I do recommend this book. I thought it was very good, real good summary of all the ins and outs of screening and all the different organ systems, from mammography to chest CT, et cetera, et cetera. Okay, so a rabbit is what everyone thinks cancer is. Imagine you were a farmer and you owned a giant farm, like 100 square miles. And in the center of it, you put a fenced-in enclosure where you kept some animals. You had rabbits and turtles and vultures. Now, imagine the vulture somehow broke out of the cage. Somebody left a gate open. It would fly the 100 miles very quickly and get over the fence, and there's nothing you could do while you were gone. It could do that very quickly. So you can't catch a vulture because it'll pop up during screening intervals and kill the patient before you can do anything, and it won't respond to treatment. You're screwed. Okay, but the thing about vultures is they're super, super, super rare. All right, now the next thing is a rabbit. Imagine the rabbit digs a hole under the enclosure fence and makes a run for the fences. Okay, now that's what everybody thinks cancer is. We must stop the rabbit, block him, stop him, do anything. Okay, and so that's how people go crazy trying to treat cancer. Surgery, take out the primary tumor. We've got to get the micrometastases elsewhere. Treat them with chemotherapy, okay? That's pretty much the standard. Okay, sometimes radiation gets used to treat the primary tumor as well, but the mainstays are surgery and chemotherapy. The surgery for the primary tumor where it originates, and the chemotherapy to kill the metastases or micrometastases. That's the standard approach to cancer. But, you got to be careful that you're not dealing with a turtle. Imagine somebody left the gate open, the turtle gets out of the fence and enclosure and starts walking for the fences, okay? Well, you know what? By the time the turtle walks 100 miles to the fence, the patient's going to die of something else, almost always heart disease or dementia, okay? So where do I see patients getting hurt? I see patients getting hurt all the time when nobody knows initially sometimes if they're dealing with a turtle or a rabbit. So they treat the turtle like a rabbit. And the patients can suffer terrible complications from it. They could die from the chemo. They could die from the surgery. They could be mutilated, okay? It can be brutally bad. So you want to be careful you're not doing that. I'll just give you one example, okay? I one time was asked to drain, back when I had my imaging surgery guided days, I was asked to drain a couple abscesses on this patient. So I held the CAT scan of the abdomen, the pelvis. He had about 5 abscesses. I could get to 4 of them. One of them was just in a location I couldn't get to. There were too many things blocking it. So, I asked the guy what had happened. And he was like, well, he was diagnosed with prostate cancer. And he went to the best university. Now, I'm not going to say the name of the university, but it's a world-famous university. You would all know it if I said it. And he said he went there because they had the new laser robotic surgery. And he wanted the highest tech, fanciest, best surgical method to remove his prostate. So, of course, the fancy robot laser bells and whistles surgery lacerated his colon, spilled stool all over his abdomen. He ends up with a whole bunch of abscesses. For the one abscess I couldn't get to, sometimes it'll have to be open surgically drained. He was kept on antibiotics for like 6 months. And it was progressively shrinking, but a rather brutal thing to have to go through. To have a whole bunch of, I used CAT scan guidance to place, what are called pigtail drainage catheters and drain all his abscesses. So I drained all the ones I could, but the one I couldn't get to, he needed antibiotics for over 6 months to treat that. And what I'm trying to say is, there's a very good chance he just had a turtle and didn't need to do anything, didn't need to know about it, okay? So, the smart way to protect your health is optimize your health and minimize your risk of cancer with low-fat, low-sodium, vegan diet, exercise, get your sleep, be religious, exercise, all that stuff, okay? And look at the Ornish study on low-grade prostate cancer. The patients who went vegetarian, exercised a little bit, managed their stress, they all kept their PSAs the same or lower. That was like 98 biopsy-proven patients compared to the control group. This is a randomized control style compared to the control group where they just continued with their previous diet and lifestyle as they were. And so what I'm saying is, McDougall will agree with this too. You don't have to be a genius. And by the way, I would never check my PSA. I don't want to know what it is. I just keep my risk as low as possible. And when your risk is really low, then it's stupid to check those things because your likelihood of a false positive is much, much, much more common than a true positive. So you're just going to end up over-treating a turtle and be screwed. Okay? And you can have a lot of complications from prostate cancer surgery. It can make you impotent very often. Okay, it can make you urinary incontinent. It can make you physically exhausted, so it's hard for you to work for months. I've seen guys suffer terrible, terrible complications from prostate cancer surgery. It is a very overrated thing. Okay, so we talked about all that. And you don't want to surgerize a turtle unless you got a good reason, because that often happens in breast cancer too, over-treatment of breast cancers unnecessarily. Okay, you don't want to risk your Johnson and your Tinkle for a turtle, is what I'm basically saying there. Okay, you know what? I think we'll call it 35B for today, and then we'll start up and we're going to go into a little bit more advanced topics about cancer metabolism for the next lecture. Hope this is helpful for you.